If you are studying for a standardized test such as the PANCE, it is really important that you study SMART. And one of the pillars of studying SMART is learning groups of pathologies, not just memorizing diseases in isolation. The reason is on the multiple choice test, you will be given very similar pathologies, and you will need to know the key differences in order to get the correct answer. Along those lines, my next series of videos, I'd like to discuss the topic of upper extremity weakness/numbness. These include topics from the neurology, the orthopedics, and the rheumatology portion of the exam. I do think this is a smarter way to teach and learn these topics because of the reasons I spoke about before. So let's focus on the key similarities, the key differences. This will save valuable space in your brain from memorizing a lot of useless drill that's not going to help you answer correct questions on the test. So without further ado, upper extremity weakness, numbness, let's get into it. In order to get a good handle on upper extremity weakness and numbness pathology, you need to have a clear understanding of upper motor neuron versus lower motor neuron lesions. So you have a lower motor neuron versus an upper motor neuron. Very simply put, anything that involves the brain or the spinal cord is an upper motor neuron. So here's a brain. Here is a spinal cord. And if I were going to draw a cross-section of a spinal cord, it looks something like this. There will be some gray matter. Looks sort of like a butterfly-shaped gray matter. Anything that involves the brain or the brainstem or the spinal cord will cause upper motor neuron symptoms. Now the brainstem and the spinal cord will give off these nerve roots, and the nerve roots will turn into peripheral nerves such as the median nerve, the ulnar nerve, the radial nerve, etc. And on our cross-section view, the anterior horn cells of the spinal cord will give a synapse and give off a motor nerve root, and that is a lower motor neuron. So when you know the lower or upper motor neuron, these will give characteristic findings on physical exam. So for a lower motor neuron lesion, this will cause hyporeflexia. So hyporeflexia. This will cause decreased in tone. Since the nerve signal is not getting to the muscles, you will get weakness to the point of atrophy and what is called flaccid paralysis. The Babinski sign will be downgoing, so negative Babinski or downwards Babinski. If you stimulate the bottom of the patient's foot, their toes will go downwards. On the other hand, for an upper motor neuron lesion, the characteristic findings are the opposite. So you will have hyperreflexia. Hyperreflexia. Tone will be increased. Instead of weakness and atrophy, you will get spasticity. Spasticity or spastic paralysis. And the Babinski will be upwards going or positive Babinski. One is clonus. One way to test for clonus is to forcibly dorsiflex the ankle, and you will have more than the normal 3 beats. If you have sustained clonus, that is an upper motor neuron finding. There's a sign called the Hoffman sign, in which you would take someone's middle finger, if this is someone's thumb, long finger, middle finger, ring finger. If you flick this middle finger, you'll get flexion of the thumb and the index finger. That is called the Hoffman sign. And you will get something called the pronator drift. If you ask the patients to put their arms out in front of them, on the side of the lesion, they will have slow pronation of their upper extremity. One good way to have a good understanding of upper versus lower motor neuron lesions is to learn about cervical spine disease. Let's talk about cervical spine. Now, if you can imagine cervical spine is surrounded by the spinal canal, so it's called jaw vertebral body here. Posteriorly, you're going to have the lamina, you have a spinous process. You can imagine a world in which, say you have a herniated disc, herniated nucleus pulposus, and it starts to irritate this nerve root, whatever nerve root it may be, let's say C6, for example. Well, that's going to cause a characteristic clinical finding. We call that radiculopathy, cervical radiculopathy. And that nerve root will be disturbed, and you will get a dermatomal pattern of symptoms: pain, numbness, tingling, weakness along that dermatomal pattern. On a physical exam, will you get upper or motor neuron lesion signs? Well, of course, you will get lower motor neuron signs: hyporeflexia, decreased tone, weakness, atrophy. In addition, you'll get signs that are specific for the neck or the cervical spine, one of which is neck tenderness. And one is a provocative exam for the cervical spine and cervical radiculopathy, which is called Sperling's. And how you would do this, there are many described ways to do this, but say this is your patient looking at you, and you ask them to turn their head to the side. This is your patient. And you will push down upon their head, and what that does is it compresses their cervical spine, and if they have a cervical spine lesion, it will reproduce their symptoms, and that is called Sperling sign. Say in another world in which the actual spinal cord gets involved, you can imagine maybe you have a little bit of a bigger or broader based disc bulge. Say you have thickening of this ligament back here, which is called the ligamentum flavum. Say you have bone spurs, arthritis building up. At any rate, you will have compression of the spinal cord, and we call that pathology cervical myelopathy. And the clinical findings you will find with myelopathy are non-dermatomal, so you're not really affecting a specific nerve root, so it's going to be non-dermatomal. Findings of pain and tingling and weakness and numbness. But the real important findings on myelopathy is clumsiness and coordination problems. That will manifest a lot of times as handwriting changes, and also balance problems. On a physical exam for a person with cervical myelopathy, they will have upper or lower motor neuron findings. It will be upper motor neuron, so upwards Babinski, Hoffman sign, pronator drift, clonus. And since, again, this is a cervical spine or a neck pathology, you will get neck symptoms, especially on a multiple choice test. You'll get neck tenderness or neck pain. And there is a provocative test for cervical myelopathy, and that is called Lermite sign. And how would you do that? Well, you would ask the patient to flex his cervical spine, so look down. They call it the barbershop test. So you're sort of looking down. This is the patient's neck, and he's looking down. This is his body, and this is his arm, for example. If you ask the patient to flex his cervical spine, you will have reproduction of his symptoms. From a demographic point of view, for the PANCE exam and other exams, cervical myelopathy is generally a disease of age. So you usually will have cervical spondylosis, which you can think about as arthritis of the cervical spine. So this will be an elderly patient with neck arthritis, and they will have these coordination problems, these non-dermatomal findings, handwriting, weakness, dropping things, and they will have these characteristic upper motor neuron findings. Now, as far as treatment, if you saw my lumbar spine videos, which I encourage you to do, This also follows what I call the health insurance treatment algorithm, which is one starting with PT and some sort of exercise stretching program. You can give anti-inflammatories such as NSAIDs, acetaminophen. If that doesn't work for a period of time, say 6 weeks, next step you order if they have neurologic findings. And both in cervical radiculopathy and myelopathy, you have neurologic findings. You get an X-ray and an MRI, after which you will refer to some sort of surgeon. Now, the only reason you would differ from this sort of non-emergent algorithm for treatment of this is if they develop the alarm finding of bowel bladder problems. So if they have bowel bladder problems, which is definitely possible in cervical spine disease, that is to sort of skip this, immediately go to the ER, get an X-ray and MRI right away, and immediately contact a surgeon. So in cervical myelopathy, you can, in extreme and severe cases, get bowel bladder symptoms. So we live in an infinite world, and thus far we have discussed upper motor neuron and lower motor neurons as two separate entities. But you can imagine there might be a scenario in our universe in which you have both. So this is my spinal cord. There's some synapse in the anterior horn cells of the spinal cord. Now if you imagine, what if we had some sort of problem in this portion where the upper and the motor neuron meets? Might you have both? And the answer, of course, is yes. That disease does exist, in which you get upper and motor neuron findings, and that is called ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease. Now, clinically, how will this present? Well, imagine this baseball player. What would he notice? He would notice asymmetric weakness, so he can't throw the ball as far. So weakness, usually asymmetric. Coordination difficulties. He noticed he was falling a lot more. And this is a degenerative process that eventually gets worse and can include pretty much any voluntary muscle. So voluntary muscle, including facial muscles. You can get a facial droop, dysarthria, dysphagia, etc. One thing that is spared in ALS is the involuntary muscles. So sexual function and bowel bladder function will be spared. So on a physical exam, if you examined Mr. Lou Gehrig, you would get the classic lower motor neuron findings, the weakness, the fasciculations, the atrophy, but you would also get the upper motor neurons, the spasticity in other muscle groups. You'll have hyperreflexia, upwards Babinski's. This is such a nearly unique situation that on a exam like the PANCE, if they give you a scenario in which someone has upper extremity weakness, any sort of weakness really, facial weakness, and these characteristic upper and motor neuron lesions that you will be looking for, the answer invariably will be ALS. The treatment for this, unfortunately, there is no cure. There's one drug called riluzole, which can extend life by a few months. But this, unfortunately, is a terminal disease, and most people will expire within the first few years, usually because of respiratory issues. Hopefully it's clear now, upper versus lower motor neuron lesions. The disease process is cervical radiculopathy, cervical myelopathy, and ALS. In the next video, I'm going to talk about all the different pathologies you need to be familiar with to answer the questions upper extremity weakness / numbness. My name is Will Kang. I'm a practicing orthopedic surgeon, hopefully helping you pass the PANCE exam.